introduction.
Okay, I think recording also is being started. So,
Yeah.
welcome everyone. I'm Dr. Swapnil. I'm intensivist physician at Apollo Hospital, Navi Mumbai. I welcome everyone today at our Apollo Mumbai Critical Care Learning Network. It's 42nd educational series, and today's topic is the rational decision on the timing to initiate renal replacement therapy in ICU. So I welcome Dr. Niranjan Panigrahi. He is from Apollo Hyderabad, but detail from the detailed thing will be told by Dr. Gunadhar Padi. I welcome him. He is a senior consultant at Apollo Hospital, Navi Mumbai, and working as consultant physician. Also, I welcome Dr. Akhilesh Tandekar. He is a senior consultant intensivist in a critical care department. I welcome Dr. Swadip Sen. He is also consultant in critical care department working in Apollo Hospital, Navi Mumbai. So I hand over from here to Dr. Gunadhar, sir.
Yeah, so I welcome you all to this very interesting webinar. So with speaker like Dr. Niranjan. So Dr. Niranjan is from Hyderabad. He is working as a consultant intensivist, and his field of interest is extracorporeal membrane oxygenation and with all the extracorporeal therapies like CRRT and ECMOs. So I think this talk is going to be very interesting, and with all your good wishes and support, we could be able to conclude our 42nd episode soon, and we'll be reaching the 50th in a matter of few webinars. So I just request all of you put all your questions at the end of the talk, and we'll be taking all the questions with us, all our eminent moderators and speaker. So with this, I hand over to Dr. Niranjan. So please start the session, and the stage is yours, Dr. Niranjan.
Yeah. Good evening, all. Heartiest congratulations to Apollo Mumbai Critical Care Learning Network, the team, their hard work, their dedication. Now, it's not a easy task to reach 42nd educational series. So, and I congratulate and I hope they will keep on doing, they will keep on educating the society like this. Now, thank you for the introduction, Gunadhar bhai. Now, today, the topic assigned to me is to rationally detect how to the timing of RRT in ICU patients. Now, in the background, I like to tell why this topic is so important. There are so many trials on the modality of the treatment, the renal replacement therapy, the dosing of renal replacement therapy, then even the place of cannulation. But there are still so many controversies regarding the timing when exactly the renal replacement therapy should be started in patients who do not meet the emergency criteria. Now, renal replacement therapy in acute kidney disease patients is it's a modality running since last few decades. Even after decades of experience also, still the experts, they vary. There are divided school of thought regarding the timing, early, less early, delayed, less delayed, more delayed. So there are so many confusing talks are there. So we'll try to simplify these things and with proper evidence. Now, what are the proper studies in this field? We'll go one by one. So now, what do you mean by the timing of renal replacement therapy? By conventionally, so renal replacement therapy is indicated if a patient is having the emergency indication or the conventional indications like hyperkalemia of more than 6, acidosis or a severe acidosis less than 7.1, life-threatening volume overload conditions, uremia or symptomatic uremia. And when we talk about the early or a preemptive or a prophylactic dialysis, that means before these indications do arrive, now can dialysis be done in these patients, or should we wait for these patients to develop at least one or more of these issues to happen? Then we should go and dialysis. Then we'll see. how the evidence has developed over time. Now, why the question of early versus late came? There are so many like pros and cons of early initiation and pros and cons of the delayed initiation of renal replacement therapy in ICU patients. Now, why at all people's sentiment for the pro or the early initiation of renal replacement therapy? Like some experts, they do believe now early initiation of of RRT can cause a better control of the fluid, electrolyte, and acid-base homeostasis, removal of unnecessary or uremic toxins from a patient, especially sepsis patients who are in AKI. Then we can prevent them in a non-renal related failure, especially the metabolic encephalopathy or uremic encephalopathy. That is the thought of the pro school of thought people. Now, what is the problem with the early initiation of the renal replacement therapy? Now, patients can get some mechanical complication because of the cannulation. Not necessarily all dialysis filters are biocompatible. Now, problems can happen because of bioincompatibility. Patient can get some kind of anticoagulations related to because of this dialysis. So anticoagulation related problems can happen. Patient can develop hypertension. Even it is postulated that initiation of renal replacement therapy can defer or can delay renal recovery in these patients. Other complications like the drug clearance, the nutrition loss, and the last is the cost. So if we initiate RRT in a patient who do not require, then cost is added factor. So we need to balance, we need to come to a single point of conclusion where exactly the RRT should be started. Now, let's see the evidence, what is available. People have tried to answer these questions way back from 2000, 2002, and till recently, 2020, 2021, the last, that's AKIKI 2, which came with the recent trial. So many trials are conducted to answer this single question. Now, let's not go back to very late. We'll try to confine our discussion and the evidences what is available from 2016 to 2022. Last 6 to 7 years, whatever the evidences came, we'll try to analyze those things and we'll try to scrutinize and we'll try to come to some reasonable conclusion. In 2016, 2 trials at a time came. One is the ealy trial, one German trial, and second is the AKIKI trial. So that's a French trial. Now, 2 trials with exactly contradictory answers. One in favor of early, one in favor of delayed. Let's see what were those trials and what are the conclusions. And after seeing those results, then there are so many investigator groups, they came forward, they tried to get their answer. Then in 2018, the one more, the ideal ICU trial result came. Again, with inconclusive answer. Then in 2019 and 2021, we'll see. So now to conclude like this, out of the 6 or the 5 trials which I'm going to quote, only one trial which favors the early initiation of RRT is the ealy, the German trial. Now, AKIKI, ideal ICU, start AKI and AKIKI 2, all these trials, they favor a delayed or a very delayed kind of RRT initiation. So let's start with the AKIKI trial. AKIKI trial, it's a French trial. So from 2013 to 16, they came with their conclusion in the 2016, they published in NEJM. So the entry criteria was adult patient in ICU with acute kidney injury, with mechanical ventilation, with vasopressors, or both. That means reasonably they have considered the sicker patients. Now, the entry criteria was like the randomization criteria was at least the patient needs to enter into the critical stage 3. Once the patient enter into the critical stage 3, they enroll the patients either of the arm. Early group, they electively dialyzed the moment patients enter into the critical stage 3. Second, the delayed group, they waited till 72 hours after entering into the critical 3, or the blood urine nitrogen to increase to 112, or any of the conventional indications like hyperkalemia, acidosis, or pulmonary edema, they do develop. Now, here I would like to stress that this is ealy trial. Now, when I will be quoting the ealy 2 trial, now the indication what we are seeing here, the entry points for the delayed group, that is 72-hour, blood urea 112, and other indications. Now, this will be the entry criteria for the early group in ealy 2. So, just right now to highlight these points. So, ealy, the delayed point, the delayed entry criteria of ealy 1 are the early entry criteria for the ealy 2. Now, coming back to ealy 1 again. So, now they randomized like interventions, and so they gave so the centers where they were free to decide the mode of RRT, duration, that to decide the interval. So the clinicians were free to decide the anticoagulation again. But they gave the discontinuation criteria when to discontinue the RRT, especially when the urine output was more than 500 ml for 24 hours. So there are some specific criteria they've given. They got 5,528 patients out of, after ruling out 619 patients were randomized. So 311 patients in the early and 308 patients in the delayed group. So let's see what is their outcome. The early group was the moment patients entered into the critical stage 3 with the dialyzed within 12 hours of entry into the stage 3. They delayed, they waited till 72 hours or blood urea nitrogen to go to more than 112 milligram per deciliter, or at least one of the conventional indications to appear. Now, they came with this is the outcome. This is the Kaplan-Meier graph. You can see there is no difference between the early strategy versus a delayed strategy. And so you can see that there is so the p-value shows there is no significant difference. They analyze the proportion of renal replacement therapy free days. They observed patient with the delayed strategy has a higher renal replacement therapy free days. Now, they concluded like this: there is no mortality difference between going early the moment they enter into the critical stage 3 or to wait 72 hours or any other indication to occur. Rather, by waiting to a delayed phase, we can get more of renal replacement RRT free days, less sessions of RRT as needed. That is the conclusion. So, ealy trial is a proposal of a delayed renal RRT initiation. Now, so they concluded there is no difference. So, ideally, we can wait to initiate RRT in these patients. Now, in the same year, in JAMA paper, so these German people, they published their trial, that is the ealy trial. So, let's see their entry criteria. Now, their hypothesis was whether early initiation of RRT in patients who in ICU with severe AKI, does it reduce the 90-day mortality or not? Let's see the study design. It's like a single center study, unlike the ealy, which was a multi-center study. 231 patients, all in ICU with KIDGO stage 2. There it was KIDGO stage 3 in ealy. In alien, it is KIDGO stage 2. They added one more marker to enter, that is a plasma NGAL level more than 150. Now, NGAL level of more than 150 signifies a relatively sicker group of patients. They tried to include sicker group of patients and to answer the question. So, between 13 to 2015, the German trial, early within 8 hours of diagnosis of KIDGO stage 2, delayed, that's either once they enter into the stage 3 within 12 hours. Now, you can see the late group of ealy is the early group of ealy group. Now, we can tell ealy is early versus very early. Now, I'll quote KIDGO, the ealy 2 as a delayed versus very delayed. ealy trial is a early versus very early. Let's see what is their outcome. So, now they included early RRT, less than 8 hours of entering into KIDGO stage 2, delayed RRT, either less than within 12 hours of entering into the KIDGO stage 3, or any of the conventional or the emergency indication of the RRT arises. What they found? They randomized 231 patients, 112, 119, 112 patients to the early RRT, 119 to the delayed RRT. Out of 112, all of the 112 early RRT group, they got dialyzed. Out of the 119 whom they randomized to the delayed group, 11 patients, they recovered. Only 108 patients required RRT. Now, so now they have given like the dialysis physician, the dialysis technicians, the strict method, the effluent flow, the replacement fluid, the blood flow. Unlike the ealy, who allowed the physician to decide the modalities, here they have given some criteria how to go out. All patients were followed for the 90 days. The vitals, RRT, recovery, everything was monitored. Let's see the outcome. These guys, they found there is a 90-day all-cause mortality, which is in favor of the early. You can see 39% in early group versus a 54.7% mortality in delayed group, the p-value 0.03. It's a statistically very significant outcome. Now they concluded. So they came to the secondary outcome in terms of renal recovery. It was in favor of the early renal replacement therapy. Hospital stay, again, it was lesser in a case of 52 in early versus 82. It's the, and the p is less than 0.001. It is very significant. So they came with conclusion that early initiation favors lesser hospital stay, more benefit in terms of mortality, and there is a significant outcome. Now, this is the overall mortality. You can see early is lesser than the delayed, and the p-value is 0.03. This is the Kaplan-Meier graph. Elaine group, very confidently, they put their message in the JAMA paper that initiating early increases the outcome because of these things. Now, they attributed the outcome because more rapid metabolic and uremic control because of the early initiation, more effective, we can prevent these complications to happen because we can initiate the RRT before the severe stage of AKI is attained, that is the critical stage 3. Now, they strongly recommended to go for the RRT at critical stage 2. So then they came with so many like theories in favor of their trial, but there are certain limitations. If we see the trial design, the entry points, the observations, so the demographic table says 95% of the patients in Elaine trial, they came from the surgical group of patients, that too the cardiothoracic surgical patients. That's one limitations. Only 5% were from the medical group of patients, so that was the greatest criticism they faced. Second is a single center trial, unlike ealy, which was multi-center. Now, at end of 2016, the world was completely confused. Two nice trials, one in JAMA, one in NEJM, one in favor of very early, one in favor of very late. Now, then there are certain investigator groups, they came forward. Now they tried to solve this puzzle and come with some answer. In 2016, so at a time, two investigator groups, they started their trial. One is the ideal ICU, second is the start AKI. Now, let's discuss one by one. The ideal ICU result came in 2018 and start AKI came a little delayed. It came in late 2019 rather than the 2020. Those people, they published their result. The ideal ICU, they tried to answer whether the early versus delayed, which was unanswered by these two groups. They tried to solve some of the limitations of these two trials. Now, let's see what are the entry criteria. More than 18, then all patients should be in ICU. At least the failure stage of rifle, that means critical stage 3. Then patient same on ventilator, septic shock, on vasopressors. That means they try to include the sicker group of patients. So ideal ICU, early group is the moment they enter into the critical stage 3. Delayed, unlike ealy, who waited to 72 hours. Now these guys, they told it's within 48 hours, or if the conventional indication for the renal replacement, if it arises, they could enroll 488 patients into their group. 246 early strategy, 242 to the delayed strategy. This is their results. Primary outcome in terms of death, they followed till 90 days outcome. 58% in early and 54% in the delayed, the mortality was, and there was no much difference. Then second, secondary outcomes, even that is not great difference. The Kaplan-Meier graph in between the delayed strategy and early strategy, there was no difference in the mortality. Now they concluded there is no difference in the early versus the late strategy. Then again, within next 1 to 2 years, the start AKI trial, which was simultaneously initiated, they came up with the results. Their entry criteria was exactly same, like adult patients in ICU, shock with critical stage 3. So this is the largest trial which is available in literature till now. Across 168 hospitals in 15 countries, they try to take all ethnic groups. 2015 to 2019, over 4-year length, they did it. 11,850 patients met the eligibility criteria. Out of that, 3,019 patients were randomly assigned. So this is the biggest ever trial available in the field of the timing of AKI. KDIGO, now their entry criteria was once the patient enter into the KDIGO 2, within 12 hours, they will dialyze, they'll put in the early strategy. Wanted to wait for more than 72 hours, or after they enter into the KDIGO stage 3. You can see here, now they wanted to keep the range little wider. The early group KDIGO stage 2 initiation, the delayed like AKI 72 hours after entering into the KDIGO stage indications to arrive. They could enroll 3,019 patients. This is their outcome. They came with conclusion in terms of death over 90 days, 43.9% in accelerated strategy and 43.7%. So, and the difference that it was not statistically significant. In terms of mortality, there is no difference even with very early and a very late also. The secondary outcomes like the RRT free, the hospital stay, or any other major kidney events, there was no statistically significant difference. Now, this is the Kaplan-Meier graph. There is statistically no difference between their outcomes in terms of mortality. So it's exactly same in the early versus delayed. So they concluded, again, there is no point in going for a early dialysis. Now, so till now, ealy, AKI, and ideal ICU start AKI. So, like to summarize here, only ealy was the only trial which was in favor of very early dialysis, which was counteracted by all these 3 trials. The patients, the sample size of ealy was only 321, rather others having a bigger number. So the problem with ealy is 94.8% of the patients, they were from the surgical group of patients. So that was again one more demerit. So they try to enter the moment within 8 hours of the KDIGO stage 2. That means it was too early going to a RRT. So probably so many unnecessary patients can get RRT in this group. So there were so many criticisms till now. So by end of 2019, it was clear that probably there is no role of early dialysis and we need to go for a delayed dialysis. But subgroup analysis in START AKI trial, it showed some of the delayed group patients who went into the conventional recommendations of dialysis, they had a higher mortality compared to the rest of the delayed study. Now that raised the questions, how much delay is the delay and is there an ideal answer between the delayed group? Now, we are by 2019, people were clear, by 2020, people were clear that, okay, we need to go for delay, but we should not go to that delay, the conventional indication will come. Now, again, some confusion arises. Then next group came the AKI 2. Now, if you remember in the beginning, I told you, the delayed entry criteria for AKI 1 was the early entry criteria for AKI 2. Now, the same AKI group, they came with an idea that we are very clear about that there is no role of early. Now, we'll see delayed versus a very delayed. Now let's see how they conducted their trial. So there, the background idea was delaying RRT. Some furthermore will probably some of the patients who do not require dialysis or some patients can recover from the acute kidney injury and who can avoid renal replacement therapy, and probably the outcome can be delayed, outcome can be improved. Now their entry criteria was critical stage 3. As I told you, their entry criteria was 72 hours. Till 72 hours, blood urea nitrogen was more than 12. This was their entry criteria. Now they're randomized into one is, so once they enter, within 12 hours of entering into this criteria, the early group versus they waited till the conventional indications arise or before the conventional indications that arise. Let's see, they could enroll 278 patients to their study. So they analyze their patients, the standard RRT versus a delayed RRT, or theoretically it is a delayed versus a very delayed RRT. Now they followed for 60 days for these patients. 278 patients randomly assigned, 137 to the standard or the early, what they say, it is a delayed group, and 141 to the very delayed group. Then they came with their result. You can see here the univariate analysis and the multivariate analysis in terms of hazard ratio for more delayed group. So it was 1.34 versus 1.6, and the p-value was 0.1, and it was not very significant, statistically significant. Then second, the 60-day mortality was 44 in delayed and 55% in the very delayed group with a p of 0.07. This was statistically significant. They came with conclusion. Now, waiting for the patients till the conventional indications they do come that increases mortality. That means they answered the part of a question. Now, very delayed strategy has an increased mortality, that is 55% versus a delayed which is having a 44% with a p-value of 0.07. So then other endpoints, the other outcomes, the secondary outcomes also they analyzed. Now, their conclusion was patients should not be waited till the conventional indication for the renal replacement therapy that do arrive. Now, right now we have all the 5 trials. Elaine, of course, it was in favor of early, no more accepted by society across world. Coming to the Ekiki 2, nice job these guys has done. They answered half of the question that we should not go to that extent where the conventional indications like hyperkalemia, uremia, symptomatic uremia, metabolic acidosis that do appear in a patient, because it is clearly proven that if those indications do arise and we wait till that time, probably the outcome is not that great. Now, to conclude my talk, so the conclusion, there are meta-analysis again in 2022 it came. So clinician's decision at bedside should have more weightage to decide the timing of RRT. The reason is, now we need to see the non-renal factor into account. It's all these trials, they have taken isolated only renal factors, the KDIGO, the acidosis, the hyperkalemia into account. But when we see, when we decide to go for RRT, we have to see the track record of a patient, how the brain is doing, how the sensorium is, how the cardiovascular system is, how the overall sepsis is. So those factors need to be considered before taking the RRT or refusing a RRT in a patient, not the renal factors in isolations. Second, the exact timing should be decided it should be individual for an individual patients. Definitely guidelines are guidelines, but the timing should be decided on the basis of a young guy may tolerate for some more longer time, but a patient with multiple problems, having some more comorbidities, having a sicker or Apache score more in the more severe range, they may require dialysis. So timing should be individualized for every patient, and individual development. Now, neither very early nor very late renal replacement therapy supports a better outcome. Now, out of these 5 trials, this is very, very clear that we should not go for a very early preemptive dialysis in those patients where there is no conventional indications. Neither we need to wait for more than 72 hours for these guys to develop a hyperkalemia acidosis to develop. Either of the extreme is harmful. So better to avoid. Now we got some limited time in between. Now in between these limited time, individual patients indications, contraindications, the situation should be analyzed and the timing should be decided. So now this is the echo message from our side. Thank you all.
Thank you, Dr. Niranjan. I think this is a very elaborative talk, and every trial you have discussed with minute details. I think these are the trials which is mostly asked to the DNB students in their exam, and this they should know by the heart, learn by the heart, and they should practice it actually. And these are the practice-changing guidelines. Sometimes these are the newer concept which is evolving in critical care, particularly the nephrocritical care medicine. So as you rightly told, the last sentence actually, it is the clinician's judgment and the individual decisions. So the trials are trials, but the clinician who is in the bedside is the ideal person sometimes to decide regarding the means the interventions to be needed, and he's the best person. And most of the times, our patients who are in the ICU, they are suffering from multifactorial problems. It is not only the kidney, but we have to take care of all the other organs, like liver, like cardiac, like sepsis, and there are a lot of physiological disturbances. So we cannot just go by certain rules, thumb rules, and certain criteria, and just say that that this patient will require late dialysis, this patient will require early dialysis. It is absolutely a multidisciplinary team approach, looking at the patient hemodynamics, looking at the patient clinical condition, looking at the other comorbidities, and looking at the other associated organ involvement. But of course, these trials are the guidelines, they are the eye opener, and they should always be there to support your clinicians in the time of dilemmas. And they are actually the evidence-based medicine. So I just request the students to put their questions in the chat box, and other moderator to just enlighten the session. Thank you.
Yeah, thank you, Dr. Niranjan, for this wonderful deliberation. So basically, so KDIGO, we just get fooled by KDIGO criteria or AKK or rifle criteria or theme criteria with the indication of CRRT or renal replacement therapy, whether it is intermittent hemodialysis or continuous renal replacement therapy. We need to see what is the indication. We should not wait till the kidney suffered and we end up doing dialysis. Renal replacement therapies can be very useful in fluid overload situations, also, especially in patients with the cardiogenic shock, with organ failure and liver failure also. So in these settings, even if the kidney injury has not set in, early initiation of renal replacement therapy will be very, very useful. Because in cardiogenic shock also, we end up giving a lot of diuretics, and then there is diuretic-induced acute kidney injury, and then we do dialysis when the patient is already probably dehydrated due to the diuretics, and then we initiate dialysis or renal replacement therapy. That is not right. Similarly, for liver, when the patient is in volume overload, okay, and the kidney functions have started probably deteriorating. Okay, so we should not end up giving them diuretics. Rather, early institution of CRI renal replacement therapy in this patient will be very, very useful. So we should not wait till the kidney injuries has happened, or there is acidosis which is set in, or there is hyperkalemia, and then we should go for renal replacement therapy. That is wrong. So indications can be individualized. Each patient differ differently. Okay, so it is this patient which is going to give us an idea when to institute renal replacement therapy rather than doing late. Though these studies, ELAN trial has shown positive outcomes, though these patients were of post-cardiac surgical patients, these patients have definitely benefited because they have instituted early. They have not abused diuretics a lot, and probably that's why they must have got positive outcomes. Whereas in other studies, if you see, they were more of a medical patients, where these patients must be having a lot of comorbidity. They must be having diabetes. These patients also must be having diabetic nephropathy. So kidney baseline functions of the kidney also must be compromised. And when they reach a stage of KDIGO 2 or 3 and then they institute dialysis, uh, whether early or late, probably the outcome may not change in these patients. So that's why selection. So
So
that is also on my side. I mean, I would like to, discuss with Dr. Niranjan as well. What is your thought process? Do we really need to follow KDIGO all the time before starting RRT, or I mean, should it be individualized? Because the indications are very many: acidosis to fluid overload to electrolyte disturbance. So, so do we really need to follow KDIGO all the time? I
Yeah,
mean, there are studies based on KDIGO only. At the moment, we don't have any data, our own Indian data or whatever. There is no data pertaining to, to any other criteria, but on KDIGO based. Can it be individualized? What is your thought process on this?
yeah, I fully agree with you, sir. Now, to conduct study, they need to have some objective parameters to start. Now they have to rely on some parameters like a critical staging or something, but that that will definitely differ the way we decide in the bedside. As Dr. Gunadhar told, like other parameters, they are not considered in these all these trials, which sometimes they take the major stake in decision of the dialysis in these patients. So definitely, it's not the exact monitoring of the critical staging. Sometimes even we do not bother also to see so okay which stage of critical patients are. We see the overall situation of the patients, then we go with the bedside decision to take a decision. There is one question somebody has
How
asked.
many times we really look at KDIGO? So, I mean, it is only for the study purpose, probably, but clinically, when we are dealing with the patient, how many times we do really calculate KDIGO scoring and all that? It is on the basis of the clinical finding, laboratory parameters, and response of the patient to the treatment that helps us to guide the initiation of renal replacement therapy. I feel so.
yeah, so there are two questions. One is like, what are the cutoff value of the urea? And the second question is, what about the diuretics? Does they really delay the initiation of hemodialysis in a patient?
Fine. I like to answer the first
Yeah,
question.
please, please.
So, is there any upper level of cutoff for urea? Now, in fact, the EKIKI 2 trial, out of the timing, they have included the urea criteria, the delayed and the very delayed. Their entry point for the delayed is 112 milligram per deciliter is the urea, or which corresponds to the 40 milli equivalent. And their very delayed strategy, they have kept one more criteria. If the conventional indications do appear, or the urea level is more than 50 millimoles. So now in their conclusion, they have mentioned urea has a major say. They have included urea level of 50 milli equivalent to be taken into consideration, even if there is no conventional indications to go for the dialysis. Again, they mention, but provided if the patient is a symptomatic uremia, no need to wait for 50 milliequivalent of urea to develop. Even if it is 35 or 40 also, you need to go for dialysis. That again, it's a clinical decision. But to strictly talk about the urea level, a 40 milliequivalent in the delayed and in the very delayed, it is 50. So they mention we should not wait till the urea level reaches 50 milliequivalent. That is the objective thing. Second question, is there any parameter where you can say Lasix will delay the need of hemodialysis? There are now this trial was in the context of the timing of renal replacement therapy. There are other studies. They have tried to find the conservative management in terms of the fluid, Lasix, and other things. Now, diuretics, they can convert a oliguric to sometimes non-oliguric AKI, but not the endpoints. In terms of the outcome or the mortality, there will not be a great difference in terms of diuretic if we are giving a patient who is in oliguric AKI in sepsis patients. This is very clearly proven. I would like to know from Dr. Gunadhar and others.
Yeah, agreed. I think it is based on the all multiple parameters. So sometimes this may be a misleading actually. Lot of times we think that the patient is on the diuretics infusion, he's passing an adequate amount of urine, but we have to look at other metabolic parameters. So like how is about the acidosis, how about the overall other organ dysfunction, what about the diuretics challenge test, whether this that particular patient is actually responding to diuretics or is just a misnomer and the numbers are only being treated. So it have to look at the other multiple factors, particularly in the ICU. And whenever the patient needs RRT, means he should be needing an RRT. Actually, diuretics is not an at all a supplement when actually the time and the cutoff for the RRT has come. So that is what, in my opinion.
Agreed.
Yeah, absolutely. I mean, as far as the diuretics are concerned, we need to assess whether this patient has pre-renal azotemia, if this patient is fluid responsive. Unless we try to challenge and we assess, we can't just end up with diuretics. So all these hemodynamic parameters, clinical parameters will help us to guide the adequacy of resuscitation is also an important factor. Unless we take care of all these things and then we try diuretics, probably we may avoid using going for a renal replacement therapy. But yes, global approach is very, very important, and all the factors should be considered at large. Do we have any other questions in the chat
But
box?
one question is there, like, what is the maximum dose of diuretics one can go for before thinking about the dialysis? Again, I think Niranjan should address this. What is your personal opinion? How many times you have started with classic infusion?
So basically, I am an opponent of diuretics, but I see so many nephrologists and intensivists that do practice. But again, we need to remember here. So the rationale behind giving some diuretic in these patients. Most of the AKI patients, now the physiology is changing over time. Initially, once upon a time, people thought it is pre-renal AKI because of vasodilatory shock, because of hypoperfusion, because of renal, because of relative hypovolemia. And the pre-renal AKI was the cause. So the theory came, probably dump some fluid or fill the volume. Then if the urine is not coming, then subject the kidney with some diuresis. That was the answer. But the physiology is changing. Now the recent hypothesis is probably it is not the hypo or the pre-renal every time. Many times it is the intrinsic thing. It is because of the renal shunting. Now, how the dialysis or how the perfusion happens, because of there is some efferent atrial, the efferent is dilated, efferent is constricted. There is some pressure gradient between the efferent and efferent, which causes the glomerular filtration pressure. Sepsis or all these inflammatory mediators, they do cause dilatation of the efferent renal atrial or the vasculature. Now that causes the shunting of the blood through the glomerulus. Even if there is a adequate perfusion, even if there is a proper volume, that is the reason half of the patient, everybody we have observed, even after giving a adequate volume, even after treating the sepsis to a great extent, also they do not respond. So the theory says it is not every time a ATN or like AIN or intestinal nephritis or a pre-renal. Many times having everything intact, it is the renal shunting. So the blood from the efferent directly go to efferent without getting filtered. Now that is the subset of patients who will not or may not respond to diuretic or fluids or whatever. The only answer will come from treatment of the sepsis. The cause here is the inflammatory mediators. We need to take care of the inflammatory mediators. Now, but in the bedside, Yes, people do practice furosemide starting from 0.5 milligram per kg body weight. People go up to 2 milligram per kg body weight. Up to sometimes even up to 4 to 5 milligram per kg body weight. Also, people do practice, but again, it's not backed with the proper evidence. It's an individual decision. People do practice. If a patient is not responding to initial fluid and the diuretic challenge, then my personal opinion is not to subject the kidney to a higher dose of diuretics. Rather, that will cause more harm to the patients. I would like to listen from others also.
No, you are absolutely right, actually. So the second question is like furosemide versus torsemide, which is to be considered. So this is one of the very important questions mostly. So if the patient is on heart failure, so primarily sometimes we use in such patients torsemide, because there, if furosemide and torsemide both belong to the loop diuretics, but the potency and they have different pharmacokinetics and pharmacodynamics properties. Basically, the torsemide is a long-acting, more bioavailability is there, and they are more protein binding. And the best part is that torsemide has some, the myocardial remodeling action. It is particularly useful where the sympathetic tone is high, and when the person in with the this furosemide boluses, they tend to pass urine very frequently, which is not actually a case with the torsemide. And because of the longer action, sometimes they produce a sustained blood level, and they are sometimes better in a patient of heart failure. So there are a lot of trials. So particularly one of the trials which is published in your PubMed index, actually, that clear cut shows that many of the studies or small audits or small center trials which has been done, furosemide versus torsemide, sometimes the torsemide is found to be more effective. But in our most of the clinical practices, we are very used to using the Lasix, particularly, and particularly the Lasix infusions in such patients where we try to give the Lasix or furosemide challenge test, and then see whether this patient is responding to the particular test or not, and followed by the dialysis, the early dialysis. How to predict which AKI patient will recover after the few hemodialysis? Any take on this?
So KDIGO, staging, if you follow, I mean, if you institute dialysis, renal replacement therapy in KDIGO 2 and 3, these patients are likely to respond to probably renal replacement therapy. But if you go with the higher staging of renal AKI, probably in stage 4, these patients are not likely to respond to renal replacement therapy. But definitely stage 1 and stage 2 will definitely respond, probably. I would like to hear from Dr. Niranjan.
Yeah. So now the definite answer is a renal biopsy. Which patient is going to recover with dialysis, which patient is going to require a lifelong dialysis. The definite answer what the nephrologist practices is a biopsy. What they do see in the biopsy, whether any viable nephron or whether any viable tubules are available or they are not. But it's not possible in ICU patient, that to a patient who is in AKI. Now the recommendation happens after 3 months. If a patient is in AKI, not recovering to up to 3 months, they do a renal biopsy and come with conclusion. Now, how to predict in AKI, fresh AKI patients? So there are some people, they have tried to answer this question from the urine microscopy test. Whether urine microscopy is called as poor man's renal biopsy. So from the cast, from the other biochemical things from the urine. Now, specifically coming to cast, if you are getting a granular cast, that means still the patient is in the acute inflammatory phase and they are salvageable. That means the kidney is still in the salvageable phase. Second, if we are getting the hyaline cast are of course the normal, Thames-12 protein, what we say, hyaline the normal. Second is the granular cast, which comes from the reversible inflammation again. If we are getting a broadcast, definitely 100% broadcast will support the CKD. But if there is a mixed broad and less of a granular cast, that means probably this patient is going to definitely require a longer time. The reason is Now, acute inflammation that comes from there are three things basically. One, when the kidney gets the intrinsic renal failure. One is acute glomerulonephritis, which is uncommon in ICU patients. Second is acute tubular necrosis, which is very common. Third is acute interstitial nephritis. That is also common. Acute interstitial nephritis happens in the autoimmune drug-induced neuropathy. Acute tubular necrosis is very common. Now, acute glomerulonephritis happens in other diseases like streptococcus and other things. They do come to the OP. Now, our patients mostly they will having a acute tubular necrosis. Which stage of tubular necrosis will revert, which will go into a permanent dialysis. There is some prediction from the microscopy of this the urine of these patients. So, if the patient is producing predominantly broadcast without any granular or muddy cast, that means this patient may require, again, it's not 100% proven, that this patient may require a longer hemodialysis period. But the definite answer is again biopsy. So,
Hi, can I say something? I, Dr. Subhadeep here.
Yeah, please.
Can I share
Please.
my
Please,
share my
please.
thought? If you can correct if I am wrong regarding the predictability of acute tubular necrosis or the predictability of acute kidney injury in the ICU patients. Probably the answer lies probably regarding on the etiology of the acute kidney injury. Like suppose somebody comes with acute kidney injury with a history of hypovolemic shock, probably mostly after resuscitation or after 1 or 2 sessions of dialysis, they will recover. On the or somebody with obstructive nephropathy, they come with their acute kidney injuries probably because of some obstruction. You remove the obstruction, probably their renal function will recover. But somebody with a acute tubular necrosis in a septic or because of any reason, because of sepsis, because of hypovolemia, because of persistent hypovolemia or persistent hypotension, then the standard literature says you go in acute kidney injury, then 50% chance you will recover within 3 months period of time. There is a 25% of chance that you will have a full renal recovery after the end of 3 months. But there is a 25% of chance that you will go on a persistent dialysis. So that predictability probably is not very easy to do. But anybody who has a kind of reversible etiology for acute kidney injury, like hypovolemia, or suppose somebody who has a come with a drug-induced acute kidney injury or NSAIDs-induced acute kidney injury, you withdraw the precipitating cause, most probably they recover completely. Most of the time they recover completely. What do you think, Balab, if I'm...
Yeah, yeah, you're absolutely right. And are there any predictors on the basis of ultrasound that we will be able to
So again,
predict?
so suppose somebody has developed bilateral renal cortical necrosis, then we can understand they will never recover. Somebody who has developed bilateral renal cortical necrosis, they will remain on lifetime dialysis. So that we can identify either on a CT or ultrasonography. Biopsy is probably
differentiation. If the corticomedullary differentiation is lost, so probably these patients are not likely to respond or recover. They will need long-term dialysis. But how early do we get this differentiation, lost differentiation on the basis of ultrasound? I mean, do we have any predictions or do we have any data pertaining to this?
No, loss of CMD happens it's very non-specific. It can happen in the AKI, it can happen in the CKD. It is very non-specific. I do not think it tells you that whether somebody's etiology it's purely acute kidney injury or not. Rather, is a better marker is the kidney size. Somebody with a shrunken kidney is definitely chronic kidney disease. Somebody with a normal kidney size, mostly it's an acute kidney injury with some amount of loss of corticomedullary differentiation loss. Probably it becomes almost clear. Okay, he has acute kidney injury mostly.
So there is one comment which is there in the chat box from Dr. Rakesh Kumar. Like we can use also photobiomodulation on renal as well as hepatic area as a part of critical care. Since it is non-invasive, produces no irritation, suitable to be applied with diuretics. it will stimulate glomerular filtration rate, anti-inflammatory as well as antibiotic effect. So it will be helpful. I don't know we have not practiced or came across this photobiome modulation on the kidney recovery. Actually, anybody has any experience on this?
Maybe we can unmute him and then we can
Yes.
ask him only what is photobiomodulation thing.
Yeah, because I don't have really any experience on this.
Can we unmute Dr. Rakesh Kumar?
Yeah, same here. I'm also not very much aware of this thing.
Another question is like dialysis disequilibrium. How common is this in the clinical practice? So I would like to ask the panelists first, like Dr. Niranjan, how much time you have encountered this entity, DD, dialysis disequilibrium syndrome, DDS?
So this is an entity which is encountered in CKD patients the moment they go for dialysis. Now, it's very difficult to detect in AKI patients. Already the hemodynamics will be unstable already. Now, the moment they go into further deterioration, it is very difficult to predict. It's because of this thing, but it's quite common. The moment we start dialysis, patients will go to hemodynamic destabilization. But whether it should be documented as a dialysis disequilibrium syndrome when we do RRT in AKI patients, that is a question. But definitely these patients, they will land in some further deterioration in hemodynamics.
Yeah, so I have one or two cases actually which resembles the dialysis disequilibrium syndrome I have encountered. So one thing is there is a progressive neurological deterioration in a patient, particularly CKD patient, as you rightly told, who have missed a few sessions of dialysis. Their urea creatinine is very high, and we suddenly try to correct those patients with a short course of hemodialysis, rapid hemodialysis, and after post dialysis they become progressively they go into neurological deterioration, like in the form of either headache, nausea. Sometimes they can be means drowsy, and they can be sometimes be like comatose also. So this is one of the scenario, or where the urea and creatine levels are very high. Like suppose a patient comes to you with a 12 or 13 creatinine, and suddenly we try to correct it with a short span of time with 2 to 4 hours session of hemodialysis, particularly in those kind of setting. So one or two cases which resembles actually dialysis disequilibrium syndrome, but whether to label them as dialysis disequilibrium syndrome or not, actually that is still debatable. So this is only my experience.
And this only happens when you initiate dialysis in a long-standing CKD patient. So it usually doesn't happen in somebody on a maintenance hemodialysis patient, but somebody who is a first-time dialysis, probably that can happen. Or even in acute kidney injury patient also, probably sometimes you can see, it has been reported in the literature, if their sodium is very low, somebody comes with acute kidney injury whose sodium is severely low, and we dialyze him. And that point of time, they develop some amount of dialysis disequilibrium syndrome kind of thing.
So basically, these are all related to the sudden fluid shift across the blood-brain barrier. So there is a development of cerebral edema and progressive neurological signs. Okay. So what about the contrast-induced nephropathy or drug-induced nephropathy? Is there a complete recovery? This is one of the favorite question by the examiner. I think most of the trainees. So
there is one interesting article has come just probably last month only. It has been published in JAMA, so which says contrast-induced nephropathy is a myth. It does never exist. It is overhyped. It is so it doesn't have any much clinical relevance. So, but again, in our clinical practice, we have seen it does happen probably in most of the patients, but somebody with a borderline creatinine who has received lots of contrast at a particular go, and somebody who is basically in some form of heart failure or severely anemic, they develop contrast-induced nephropathy, or somebody who is diabetic. So diabetes is one of the very important predisposing factor for contrast-induced nephropathy.
So the particularly, yeah. So the volume
of the hypovolemic or not hydrated, well, these patients are likely to develop a contrast-induced.
So particularly the volume of the contrast, actually sometimes it matters. like we have seen few cases, particularly in patients who were planned for angiography and angioplasty, where the volume of contrast exceeds from the routine normal contrast. Like some patients, they have received a contrast of around 400 ml, 500 ml. And in fact, in one patient, the contrast volume exceeds around 600 ml or something. So particularly there is a gradual rise in the creatinine in the post procedure period on third day, fourth day, and they usually land up in this contrast induced nephropathy kind of scenarios. So, and they require dialysis. So that's
Non-ionic contrast are also available, which has reduced. It is supposed to be considered that it is non-toxic and probably it has reduced incidence of acute kidney injury with non-ionic contrast. But these contrast agents are also associated with quite a lot of acute kidney injury. They are used in high volumes probably. So it is related to the volume and the hemodynamic status of the patient, resuscitation state of the patient, and pre-existing now kidney disease. So these factors can contribute to further progression of acute kidney injury in these patients.
what is the role of N-acetylcysteine, Dr. Niranjan?
So definitely there is no great role, but yes, all the guidelines they mention, at
It is
least
not harmful also.
it's a harmless molecule. So people recommend it everywhere. Even we do use to these patients for at least before contrast. But again, there is no proven role that N-acetylcysteine can actually prevent the contrast condition of the
Any role of IV fluid with soda bicarb, and then resuscitate this patient before contrast and after contrast. There is a trend, and some clinicians they use this combination of fluid with soda bicarb and give it over a period of time till at least for 24 hours, something like that. And it is postulated that this prevents further injury to acute kidney. Like, what is your thought process in this regard? Using soda bicarb with fluid, DNS
No,
point along with that soda bicarb is added and then it is given in infusion.
even the same situation here as well. So I have seen few nephrologists, maybe 5 years back, they were routinely advising a, like hydration and soda bicarb infusion. But at least recently they have stopped practicing that thing. That way again, it was on the basis of a small trial which came around in 2016-17. The soda bicarb can prevent, but it was never proven subsequently. We do not use soda bicarb, but yes, a good amount of hydration. Second is N-acetylcysteine, even without any proven role, proven evidence that we do use, and sometimes we go for only renal replacement therapy if the patient is on dialysis. So that's what we do practice.
Absolutely agree.
Yeah. Any take on drug-induced renal injury? What is the outcome normally? Most of the drugs they cause, like you told, interstitial nephritis, and some of them cause tubular injury. So particularly the analgesic-related interstitial nephritis.
But when the
Again,
opening agent is removed, this
Is there a
patient then
complete recovery of the renal function most of the time?
so the only challenge with this drug-induced or this antibiotic and this NSAID-induced nephropathy is it takes at least 48 to 72 hours, and some patients do develop a delayed acute kidney injury because of these things. So basically it's the avoiding these medicines, but many of the antibiotics which are nephrotoxic, which we are bound to give, we have no options otherwise. Colistin, we know we have to give it. Carbapenems, we know they are nephrotoxic, but we are left with no options. We have to give it. Little bit judicious use with a dose modification, especially in a subset of patients who are more vulnerable to go for this AKI. To do a dose modification is more effective.
Right.
any role of biomarkers because we are using biomarkers for every other disease conditions, but we have not been able to evaluate any single better biomarker to predict acute kidney injury progression or can we predict. So do you have any thought process of this, Dr. Niranjan? I mean, this is
two biomarkers which we were using, and currently the NGAL and cystatin C, these were the two biomarkers which we were using since 2016 till 2019. So different nephrologists they were using to predict basically. But recently only they use NGAL. That the idea is to detect acute kidney injury before the creatinine level goes high. Now it's proven that by the time the creatinine keeps up jumping, even 0.1 to 0.2. Now that will happen only if at least the 30% of the nephrons they become non-functional, either function-wise or structure-wise. That is the theory. So NGAL increases much before. They've given a cutoff, a absolute increase of NGAL 25 to 50. They do consider in some patients. But again, it's a like not a routine practice in every patient to predict. But yes, in some patients who are vulnerable, whom we are giving at least 3 to 4 nephrotoxic medications, we do not very frequently, but sometimes we rely on that parameter. NGAL is being practiced. Cystatin C, nowadays no one is doing, but I like to listen from you people if at all you are doing cystatin C.
No, we also don't have much experience with cystatin C. Possible right now the best indicator I feel right current scenario where we don't have the facility is the urine output. So probably the patient is sick, the early urine output, it is the only options available with the bedside intensivist. Because before the urea and creatinine jumps, it is the first thing to reduce in a patient, and it shows actually the peripheral perfusion. So that is the reason it is very vital. So this was a very interesting talk by Dr. Niranjan, and I request all the delegates to attend to our upcoming physical course on this nephrocritical care, which we are going to conduct on 21st and 22nd April. And all of us of the faculty there, including Dr. Niranjan also. And this will be a very interesting session where we'll be giving them the opportunity to practice the CRRT machines hands-on and the different clinical case scenario discussion bedside. So the brochure will be coming soon. So and they can register actually. The seats are very much limited, and I of course really thanks to all the moderator today for this session. I thanks Dr. Niranjan particularly to take out his time from his busy schedule. I know he's working in a very busy center where he does all these ECMOs, CRRTs, and a lot of this extracorporeal therapy. And I really thanks to him. And
Dr. Rakesh wants to speak on. He is unmuted now. He wants to speak on this new therapy. Can we unmute Dr. Rakesh and welcome Dr. Rakesh? Over to you, Dr. Rakesh.
I think he's not unmuted. Can the admin can unmute Mr. Rakesh, Dr. Rakesh, I mean? Oh, I think it is difficult because he has already made all the delegates in the mute mode.
I think he can unmute himself. He's there. Screen is visible.
Yeah, Rakesh is now, Dr. Rakesh is now co-host. You can hear from him now.
Hello.
Yes, Dr.
Hi,
Rakesh.
Dr. Rakesh. Welcome.
Hi. Sir, I am already working on photobiomodulation and trying to spread it to different areas of the medical field, especially in the critical care.
Yeah, Dr. Rakesh, just to interrupt, can you just give your introduction? Which hospital you are working right now?
Can you keep the mic little in front?
Yeah, your voice is a little bit low. So can you just come closer to the mic?
Okay. I am just telling that I am working right now with 3C critical care and Six Sigma, which I already connected with Apollos and all. And we are working with them with critical cares. And so when I received many cases of which are on the dialysis in the nephrological conditions, and after being treated for just 2 or 3 sessions of photobiomodulation by using the low level laser, a cold laser, okay, I found that the creatinine level is coming under the normal ranges. The dialysis rate sequence is also reduced. We don't require too much of dialysis. The cases for the renal transplantation requirement also decrease a bit. So this produces a better incidence that since it is non-invasive and it can be used in any type of critical care, so we have good option to add it. So by the meetings we had with Six Sigma and critical care, 3C critical care, I found that they inspired me to generate some institutional effect that to produce medical professionals who could generate and provide the services to the hospitals with photobiomodulation. And it is very acceptable. Yesterday also I treated some with a vocal cord problem with photobiomodulation. A singer from Canada visited here in India for his presentation international fest at Bharat Bhavan, and he visited me because he has problem with the vocal cord. And after photobiomodulation, yesterday he has performed at a national international platform and did the magic. So these are some quick results with the use of non-invasiveness, and I am trying to produce the medical professionals who could be helpful in every critical care hospitals in India or and abroad. So we have to look after that. Soon I will give you the good news. As soon as it will be on the platform,
What is the
soon I
principle?
will
What is
send
the
you over.
principle, Dr. Venkish?
Can
What is the
you,
principle?
can you
Yeah.
put all these details in the chat box so that our students can note that?
It sounds interesting, actually.
Yeah.
It sounds very, very interesting. But how do you do it? Malab? Do you what machine you use and all?
We have to use different sort of light waves. Like if we use a red laser, it just penetrates 1 centimeter. So if we use infrared laser, it can penetrate up to 3 to 4 centimeters, and near infrared could reach up to 5 to 7 centimeters with no side effect, no feel at all. It is a good nephro-regenerative protocol and approach which could be helpful in even condition and critical care. It will very help. I found it in many cases. Till
So
now, I just
basically,
want
the laser light is emitted inside, and it
it can
works.
go in. It is cold laser. You can search every detail by searching effects of LLL on different critical cares like in renal disease or in the cardiac conditions or the even diabetes, liver cirrhosis. Every research is available at online also. Anybody could go through the effects of LLL. It is called low level laser therapy. Okay, which is now termed as photobiomodulation. So it is effective, and we can go through very easily on the research papers available everywhere and research gates and all. So it is very beneficial for everybody. Soon it will be available for every hospital, sir. I am trying on that aspect also.
Yeah, it
Good,
sounds
good.
good. I think we need to see if it's working. Okay.
Yeah.
Please keep in touch. I will remind you as soon as possible.
Thank you. Thank you. Thank you.
Thank you, sir.
So
Nice to meet
can
you.
we conclude the session? Dr. Gunadhar,
Yeah.
can conclude.
Yeah, so I really thanks and thanks to all the delegates and all the panelists, the moderator and our speaker. And I would also like to invite you for our next program, which is in the next coming Thursday, 7:30 p.m. And the link will be active. We'll be sharing the link soon. And also I'll send you to the link also to Dr. Niranjan also. So do attend our program, and thanks all of you for today's
Thank
webinar.
you. Bye bye. Good night, all of you. Thank you,
Thank
Dr.
you all.
Niranjan.
Thank you. Bye bye.
Thank you, everybody.